I'm thankful and pay my regards to the organizers as well as the colleagues. And this is an ongoing topic since long. After 2015, the scenario has changed. I have to argue with my younger brother Tapas. So, early thyroid cancer. Let us come to the topic. Lobectomy or total thyroidectomy? I am going in support of lobectomy. So it's a debate, it's not an argument. The argument is always which is forced upon you. You do this, you do this. But debate is always based on science, which finally comes with strongly agree or disagree. So, what do you want? Which is better? The iPhone or the Android? There is an ongoing debate. Again, the cost effective. So I usually compare in this way. So I will be going through this introduction, then statement of facts, then confirmation of the proof. I will try to prove my points, then refutation for the audience, and conclusion by you. So incidence of papillary thyroid cancer is rising, and it is due to over-diagnosis and over-diagnosis of small tumors, and the over-diagnosis is because of the good expertise by the sonologist in smaller cities of the country, which is not earlier. So over-diagnosis, over-treatment, and those over-diagnoses are over-treatment with the tumors which might have been indolent. There is a cross-sectional studies above 80 years, how many persons have papillary thyroid cancer, and it has seen that in the autopsy, 20% of papillary thyroid cancer above 80 years, those which would have been remained lifelong. So the 2015 ATA guidelines, T is an important factor which is clear-cut recommended less than 1 centimeter, more than 4 centimeter. Between 1 to 4 centimeter, there is a confusion line. So those 1 to 4 centimeter T1, T2, N0, in those areas we are debating since long. But the debate is going more earlier, before 2015, before 2016, 71% was total thyroidectomy for tumors less than 1 centimeter. After 2016, the data is showing that it has come down to 15%, 76% to 15%. At the same time, the less in complication rates. So the 2015 ATA guidelines is less is more. What is that less? And the less is more is the theme of 2015 guidelines. Less fine needle aspiration, less radioactive iodine, less extensive surgeries, heroic surgeries, less thyroglobulin assessment, less recurrent palsy, less hypocalcemia, less hematoma, less hospital stay, early going home. So mastery of these guidelines will help clinicians for the to-do is less, providing responsibility for individual therapy. Despite this existing uncertainty, again ATA strongly recommends either total thyroidectomy or hemithyroidectomy. But again ATA here is with a 2B level of evidence, not 1A. So although the acknowledgement that the recommendation is based on moderate quality evidence, there is the catch-22 factor. So we have to address that. What are the exclusion criteria for 1 to 4 centimeters? These are the tissue invasion by imaging techniques. Example, tissue more posteriorly, just even a small tumor, just very close to the esophagus, or tissue, especially tumor in thyroid, tracheo-esophageal groove. Lymph node involvement, presence of distant metastasis. Suppose you have done hemithyroidectomy 1 centimeter and the follow-up, there is distant metastasis. History of neck radiation and papillary thyroid cancer. Some aggressive variants like tall cell variant, sclerosing adenosis, Hobnell variants, incomplete surgical margins by the untrained surgeons, positive lymph nodes, post-operative vascular invasion, bilateral. These are the people, they are excluded. Again, my dear friends, I will show the data to you. 25 years follow-up, only out of 61,000 patients, only 22 heart death if these criteria were taken. Only 22 with a, that I'll come. So again, let me go for a statement on my facts. What are the proofs, scientific data I can procure to you? So you see, the study is 61. So if you add this 1,20,000 patients data follow up with good evidence, good institute, what you more? क्या चाहिए आपको? Then overall survival, same, 1,20,000. जान लोगे क्या बोलते हैं इसको? Then you see, this is the landmark study. 25 years follow. Study started 1986 to 1995. Publications came 2014. And you see, the 25 years follow. Remnant thyroid recurrence free rate 93, lymph node recurrence free 90%, disease recurrence free 93, 95. So everything is above 90. Only we are fighting for those 10%. And out of the 10%, how many are leaving, that we have to see. Then this is 889 patients, and all these patients comments only completion is only 6% initially, 4% during follow-up of 10 years. Then here total thyroidectomy, hemithyroidectomy, 10-year disease-free, same. No difference in recurrence. It is a very good study. Of course, sample size less. Recurrence-free overall survival, Japanese study, and no difference in recurrence. So these two are my. There are not many papers, but I was going through each paper. That's why I took time seeing what are the inferiority in each paper. I could mark out that many things have been addressed in these papers. These papers are important. So I have left my colleague motionless, soulless. He has only 3 questions to ask me. Only with 3 questions he can argue with me. Before he asks me the questions, let me answer it. So that I think my colleague will tell that, okay, Dr. Dilip, I should not go to the IS, let me stop here. What are the 3 questions? So I am ready with the answers. What are the answers and what are the questions? 3 reasons for total thyroidectomy. First, tumors in the contralateral lobe. And 61,000 60 and 25 years follow-up. You see, this is the data. So the conclusion, lobectomy without radioactive ablation offered excellent results in one, no doubt about this. Dr. Tapas, my opponent. Second question he will ask me, to facilitate radioactive iodine, let me ask the questions. I am practicing here in Orissa for last 12 years, and radioactive iodine only one center. This was studied, and the conclusion is more selective use of radioactive iodine has been advocated. The third question, thyroglobulin as a tumor marker for hemithyroidectomy. Then conclusion is lobectomy is sufficient. I am not going in detail. The third question also nullified. It is not necessary. The question he can bombard to me, and I can bombard to him the questions that by total thyroidectomy, recurrent laryngeal nerve palsy and calcium, with out of 14 years practice, recently I have done probably two long-term hypocalcemia. I know the amount of calcium tablets they take. And once the superior laryngeal nerve palsy for a singer or a voice, for a teacher, the life is finished. So, my dear friend, these are your drawbacks which you have to address. And for these drawbacks, I am not going for total thyroidectomy in low-risk patients. So if recurrence, these are alternative arrangements are there. And last part is, he can put me last soft question, cost-effective analysis, where I have to slightly take one step back. But again, he will tell that EG for follow-up thyroglobulin, obviating need of serial USG neck, but I will argue lifelong thyroxine, regular blood investigation, regular coming from a 200-mile distance to you, spending in trains, spending in cars and spending in sonography, and possible for the bone health calcium supplementation. With the changing protocols management, so even if hemithyroidectomy emerging as a more cost effective, this is the only study available for cost effective analysis of both. So these are the guidelines, as you know all. So I think I like you and you will agree with me. Thank you.